Thank you for joining us. Now, Nigeria is working hard to fight HIV/AIDS. The country is integrating its HIV response into the health sector, making sure people have access to testing, treatment, and care. Nigeria is also trying to reduce stigma and discrimination against people living with HIV/AIDS. But despite progress, Nigeria still faces challenges like dwindling donor funding and service delivery gaps. But with continued efforts, Nigeria hopes to end AIDS as a public health threat by 2030. Now the question is, will Nigeria meet its 2030 goal of ending AIDS as a public health threat? Now, joining us on the show this evening, we have three guests. We'll start with Dr. Iorhen Akase, Consultant and Chief of Infectious Disease Unit, College of Medicine, University of Lagos and LUTH. And we also have Dr. Nesochi Okeke-Igbokwe, CEO, Dr. Nesochi LLC, Internal Medicine Practice, New York City. And we also have Dr. Olaoye should be joining us, Omolola, that's Olaoye Omolola, resident doctor, internal medicine, Federal Teaching Hospital, Ado-Ekiti, Ido-Ekiti. But let's begin with Dr. Akase and Dr. Okeke-Igbokwe. Thank you so much for joining us this evening.
Thank you for having me.
All right, let's begin with Dr. Okeke-Igbokwe. Now, as we approach the 2030 target, to end AIDS, can you elaborate on Nigeria's current progress in integrating HIV/AIDS into the broader health sector initiative?
Yeah, so Nigeria has taken bold strides to try to integrate HIV care into the mainstream of healthcare initiatives in the country, especially trying to target underserved regions, rural areas that sometimes it's more difficult for those individuals in those areas to get access. So in the grand scheme of things, they have implemented certain initiatives, but there are certain barriers that are limiting the progress. And we have to determine if it is realistic for us to reach that target for 2030. I think some of the main barriers, one thing is funding. Nigeria typically relies on donor funding rather than domestic funding, and that proves to be one of the limitations that we see when it comes to the progress that we need to make. There are also other barriers that are an issue as well in regards to access to the HIV care and treatment, and broadly education, knowledge about HIV prevention and treatment modalities in some of these underserved areas. So government does still have a ways to go in ensuring that, yes, some of the initiatives they already have in place are fortified and we have more resources on board so that we can actually help the majority of the population.
Okay, now let's hear from Dr. Akase. Now, she did say that there are certain barriers that are limiting the progress, to ending AIDS by 2030. Now, with an estimated 2 million Nigerians living with HIV and a national prevalence rate of 1.4% among the population aged 15 to 64, what would you say are the key challenges to ensuring access to HIV care, particularly in the rural and underserved areas?
Yeah, thank you very much. I think we must commend the progress, like Dr. Moko has said, that has been made, over the years. Truth of the matter is that now we're seeing less cases. Before now, we had people coming with HIV for the first time, very, very sick, already having complications, and having a very poor lifespan. The immunity has been damaged severely from late presentation and all of that. That has improved significantly. But like she rightly said, in the rural areas, because one, there are challenges, for example, with access. Some of the places don't have motorable roads, so the distance they need to travel to come to hospital to access this care is long and tortuous and sometimes difficult. Two, people don't have the funding to even make simple trips to come to hospital, to access this care. And to a large extent, some of the private healthcare facilities that are closest to the grassroots may probably not have the kind of infrastructure they need to provide a kind of care. So, for example, basic things like CD4 testing, checking for organ function like, kidneys and all of that, it's a problem, So when they go there, they still have to refer them to bigger facilities, and transportation, logistics, movement becomes a problem. So yeah, there's still a lot of work still to be done, especially at those, areas where there's, but I must say that a lot of progress has been made, yeah.
All right, now I'm being told that Dr. Olaoye Omolola has joined us. Good evening, Dr. Omolola. Can you hear me?
Yes, I can hear you. Good evening.
All right. Thank you for joining us. Now, Civil Society for HIV and AIDS in Nigeria, that's CHISAN, has actually emphasized scaling up HIV testing and treatment, especially in hard-to-reach areas. How do you envision overcoming logistical barriers to HIV testing and also treatment in these regions?
I think that our government needs to do better in providing this the needed equipment, needed testing facilities. Like for instance, now some of our primary healthcare centers don't have access to all this equipment for testing or prompt testing, and then for them to be referred to appropriate centers. This could pose challenges in people being detected early and also getting started on treatment early. Because one of the things we know about HIV is that when there is low level of the viral load in the blood, there is low level of transmission, which will further halt the disease progression in communities. Like for instance now, the burden of HIV has reduced with the onset of treatment like the highly antiretroviral therapy, which has been put in place now. Like there is about 20% reduction in about 20% reduction in the burden of disease. The reduction in mortality associated with there is also reduction in mortality that has been associated with AIDS. So if our government could provide necessary funding, I believe that those areas will be targeted, and those areas would have increased access to the testing.
Okay, now speaking of antiretroviral treatment, let's pass the next question to Dr. Okeke-Igbokwe, if you can hear me. Are there specific steps that you feel the government should take to ensure equitable access to the treatment, that's the antiretroviral treatment, particularly in these marginalized populations?
Yeah, so the government, they've restated and re-emphasized their commitment to trying to provide access to Nigerians. There are actually designated facilities that do provide free antiretroviral treatment, but I think we need to acknowledge that there are some systemic barriers that can hinder one from being able to even access any of those free facilities that might be available. So let's say, for instance, one that is in a rural area. One of those barriers can include just having the transportation to make it to one of the facilities that provide free care. There are issues with just financials. Is there even that economic support for an individual with this diagnosis to thrive in that kind of environment, have access to transportation, have enough food on the table to eat on a day-to-day basis, have the ability to take care of themselves and afford the costs associated with any potential complication from an HIV or AIDS diagnosis. So there are multiple factors that we really need to keep in mind. So yes, government has made some of these strides to provide some of this treatment for certain populations, but is that really enough? Are we actually targeting some of those extrinsic factors and intrinsic factors that make it difficult for those to access care when it is provided by the government?
All right, now moving away from that, one of the 2030 goals of Nigeria is to prevent HIV in children. And I'm passing this question to Dr. Akase. Now, if you take a look at that, we have, there's been significant progress, 160,000 children in Nigeria at the moment are living with HIV, and also mother-to-child transmission. The rate remains high at 23%. Now, what specifically is being done to, reduce the mother-to-child transmission and also improve pediatric HIV care?
Yeah, thank you very much. I think this is one of the vulnerable groups for HIV. Any child with HIV is already, severe disease. Generally speaking, children do not have risk factors for HIV on their own. So control of HIV focuses primarily, on the mother, first, even before she conceives, while she's pregnant, making sure the antenatal care is optimized, and how she delivers and the activities that happen after she has delivered. So, countrywide, a lot of efforts have been made to make sure that every woman, at least most women, should have access to antenatal care. And in any antenatal facility you go to, HIV testing is routine, and linkage to care follows. So where you're having mothers who cannot have come to antenatal, care is a big problem. That's the biggest, challenge to preventing, because if you pick HIV in the mother early enough, you can then, institute the care, that is needed, to do that. And as we scale this, of course, that comes to after they've delivered. How does the child feed? Does it breastfeed? And all of that. These are all the things that we'll put in place. But as we scale up, and I think it's very instructive, right? That we need to now begin to look at. We want to reach as many people as possible, right? That's provide quantity to many people. But we need to look at the quality of care that's been given, to people. It's all fine and good to reach more people, but the more people you reach, especially when it comes to children, because after birth, they need to provide the structures in place to now you're reaching them, but not be able to provide the quality of care they need can still leave a gap, in there. So all of these steps must be put in place and at a high quality, for that matter, to make sure that you prevent because any child, once they get HIV, their immunity is damaged significantly, and by the time they reach their teenage years, if their care is not taken, they already have complications, compared to others. So this is some area that a lot has been done, but still. Some attention is to be paid, closely.
All right, let's hear from Dr. Omolola, the same question to you about mother-to-child transmission and also, pediatric care.
Okay, thank you for the question. Well, for prevention of HIV in young children, I believe that it's about the mother, mostly about the mother. Most of them, we have to start preconceptual care. If they already have HIV, the first thing is for them to be tested, cancelled and tested. Once they know that they have this, in pregnancy, prior to pregnancy, there should be preconception care where they would have they will be commenced on hearts. And during the pregnancy period too, they should also be commenced on. If it was detected during pregnancy, they should also be commenced on hearts. But and in the case of delivery too, once they are delivering, some practices should be mitigated against, like rupturing of membrane in them, using instrument for delivery. Those and also probably there are some other things too that are involved. You want to delay rupture of membrane till the time when they're about to give birth. You will want to, and also if there is a need to do CS, although it's not like it is indicated for them to do CS, but in case of vaginal deliveries, you must ensure that you prevent rupture of membrane early, and also to prevent use of instrumented deliveries. And after delivery, there are some they should also become tested. The child should be tested with NAT. After delivery, after this delivery, they also should be commenced on drugs too. And one other thing that should be done for them is that if they should stick with either breastfeeding. If they are doing breastfeeding, they should do exclusive breastfeeding. Not that they will do exclusive. They will do complementary feeding in addition to their exclusive feeding. If they want to feed with with if they want to do complementary feeding, it should be basically exclusive, or they are doing they are giving feeds, either of the two, but those two cannot go together. And if there is any sore in the mother, if there is sore.
Okay, well, we seem to have a connection issue with Dr. Omolola, but let's move to Dr. Okeke-Igbokwe. Now, let's talk about stigma. Stigma and discrimination, which is, which often discourages people from getting tested and also accessing treatment. Can you tell us what strategies should be implemented to create safe spaces where people can, come for testing and also be able to access treatment without fear of being stigmatized?
Yeah, so this needs to really begin at the community level. We need involvement of community leaders, potentially religious leaders, traditional leaders. It's really going to be support from the entire community. These support groups within the community need to be available, need to be able to educate individuals in the community about what HIV, AIDS, what it's all about. They need to really remove and debunk a lot of the myths that are associated with anyone that has this diagnosis. And I think more importantly, these safe spaces need to really prioritize and focus on confidentiality for individuals that do have any concerns about the potential diagnosis. They need to really garner that support to let any individual know and be aware that if they do have this diagnosis, it is not a death sentence. I think at the core of it all, there really needs to be this focus at the community level about education, really demystifying some of these myths that are out there that really hinder individuals from moving forward with the care and treatment that they require. So safe spaces are crucial, and again, it needs to start at the community level.
Okay. Now, talking about safe spaces and all, Dr. Akase, how effective are the current anti-discriminatory laws at, both the national and state levels? And how is the enforcement of these laws helping to create an inclusive environment for people living with HIV?
Well, I mean, that's a very interesting question, isn't it? You can look at it two ways, right? One is, on the societal level in terms of what laws are being passed and how much compliance is being done. I know that to a large extent, this is one reason why some people are not accessing care. And generally, we're seeing less and less instances of public embarrassment for people who sort of identify, in a particular way. So generally speaking, I would say, yeah, there's more acceptability and all of that. But a lot of work still needs to be done at personal and at healthcare level. For example, if somebody comes to hospital, and we see this a lot, most times I have to ask somebody in confidence, what's this and that, and they are comfortable to say. But most times at facility levels, when people come, they are unable to come up and open and tell you that, this is this who I am, or this my my orientation and all of that. Because at the end of the day, you cannot control how people respond to people. You cannot control the kind of attitude, others, are going to get when they come to hospital. But, a lot of work needs to be done. And that is why the move to integrate, routine healthcare services into routine healthcare is very, very important, because currently what you have is, if you go to the hospital, you see the HIV clinic or whatever they call it, heart-to-heart or whatever, is set in a particular place in the hospital. And anybody who's walking towards that direction, everybody can say, oh, that person is going to access HIV services. So they know that automatically somebody's labeling them. But if they come into the hospital, they go to the OPD just like any one person, they're able to access healthcare services there. They go during antenatal, wherever they're coming for, and they're able to get healthcare service there. Nobody's going to tell who is coming to access what. And I think that will go a long way in making people feel comfortable, knowing that they are not separate type of patient. They are a patient coming to hospital to access care, just like the person with diabetes, the person with hypertension, the person whatever. So they're not different. And I think that's going to help people, at least within hospitals, government needs to do what they need to do, security agencies to make sure they're protected. But when it comes to accessing HIV care services, that desegregation needs to happen. Where now they're segregated, they say, oh, when you come, go there. Or if they come to hospital, they go where everybody else is going. Nobody knows what is wrong with somebody until you talk to them. So I think that's why integration is quite key. Helping with the anti-discriminatory laws, we're having a country at the moment. Yeah.
Okay. Now let's hear from Dr. Omolola. Now, thank you for joining us back. Speak to us. They've talked a lot about, stigma, especially at the community level. Can you tell us what steps should or are being taken to address HIV-related stigma at that level, particularly among health workers, families, and other key societal groups?
Thank you for that question. Well, I think my senior colleague has said a lot about it already. But one thing that I will add is the fact that I want to emphasize the importance of educating the populace about it, how it can be transmitted and how it cannot be transmitted. Some people don't know that even hugs cannot make it to be transmitted. You understand? Some people are scared of shaking hands, hugging a person who is living with HIV, those kind of things. We need to debias people's mind about it. I think that we should focus more on health education of the general populace on this. Once this kind of stigmatization that is given to those who are living with HIV is not there again, then people will embrace them more, and they would those people will not feel that the stigma will not be on them. They want to access the healthcare system. I've seen some patients who would rather not access healthcare facility within where they are living, because they feel that if people are aware about it, they would not want to relate with them. They would rather go miles away to those other centers about it rather than coming to an healthcare facility that is close to them. And with that, with miles away, the transport fare might be too heavy on them to even go to that place, and them missing their drugs and appointments. So I believe that when we educate the populace more, when like use of radios, television, broadcasting it far wide about how it can be transmitted, I believe that there would be improvement in people accessing HIV treatment in the hospital.
All right. Now, Dr. Okeke-Igbokwe, the idea behind the theme for this year, has to do with health being a human right. Now, can you tell us how Nigeria's HIV strategy aligns with global calls for the prioritization of human rights and gender equality in addressing the epidemic?
Yeah, so gender-based violence and gender inequality has often been cited as a huge determinant of a woman's HIV risk in Nigeria. We still have cohorts of individuals, of women, who are subjected to, or let me say girls, subjected to childhood marriage. There are still issues with domestic abuse, sexual violence. These are threats, basically, to one's individual health, to one's HIV/AIDS risk moving forward. So the government and Nigeria, they really need to align a lot of their initiatives to ensure that we are addressing some of these issues that still continue to occur in Nigeria. All of these initiatives that we have in place at this time to address HIV treatment and care, yes, that is great, but there are these other factors that we cannot dismiss. So we need to ensure that there are these initiatives in place to really address and understand that women are at risk of these issues with gender-based violence so that we can minimize that and improve outcomes in the future for potential exposures to HIV/AIDS.
Oh, okay. Now, Dr. Akase, let's hear from you, same thing. Can you, first of all, help us break down the 95, 95, 95 targets, and also share the main challenges that Nigeria must overcome to meet them come 2030?
Yeah, fantastic. So the 95, 95, 95 targets by 2025, the aim is to make sure that 95% of people within the community in Nigeria, in this case, know their HIV status, and that those that know their HIV status, 95% of them should be on treatment, effective treatment, and those that know are effective treatment should be fully virally suppressed. In other words, the treatment should have made their viral load, to become undetectable, and because it's important. Because once viral load becomes undetectable, then the risk of transmitting to other people becomes low. And I think this is a very important public health tool. It is beneficial to the individual, but it becomes a very important public health tool in trying to reduce, because we know that last year, over 1 million people, globally had new infections. And so long as people are having new infections, it means that people who have the infection are not being treated well, so they're able to pass the infection, on to other people. And, the goal to make universal health coverage by 2030, clearly, we know that now we're interested in the 95%, but we still have the 5% that is not covered. And that key group, at the best, there's still going to be ongoing transmission within the community. And so the aim, beyond 95, 95, 95 is to, aim for 100, 100, 100. And a lot of, work has been done along this way. And I think, like, we're coming back to our setting in Nigeria, for example, is what are the challenges against achieving even the 95, 95, 95, which some of them we have, we have highlighted. One of which is to make sure that, because even when somebody is has known his status, 95, 2, is on treatment, to achieve the last 95, his treatment needs to be regular, needs to be effective, and needs to be monitored. So if you have supply chain issues, for example, there are some facilities where and I think we mentioned this, that most of the medications that have been supplied within programs for HIV are completely funded. Patients don't pay for them. So they need to rely on government supply and other donor supplies, to make sure that supply chain is maintained. If there is any interruption for whatever reason, the supply chains or the facility didn't full, or they didn't push on central, and they run out of medications, which happens, you say, oh, we're run out of medications, come back next week. All of that are challenges to achieving the 95, 95, 95 target, as well. Secondly, and which the issue I highlighted earlier on, is that as we now, HIV patients are living longer. Some of them, their problem is not primarily HIV anymore. They now have issues like diabetes, hypertension, stroke, and other problems. And if they're only coming to the HIV clinic, they may die early, not from the HIV, but maybe from the heart stroke. Nobody was taking care of that stroke. Because if they're coming to HIV clinic, they just know, I'm coming to hospital, somebody's looking after me. But nobody's checking them for diabetes, nobody's checking them for hypertension, nobody's checking them for risk factor for stroke, and all of those other things that can happen when people live longer. So all of these are issues that, we need to provide a holistic approach to patients that have HIV beyond trying to meet the 95, 95, 95. I would say key target for public health, mitigation of transmission. The patient individually needs to be looked at, and properly cared for. Yeah.
Okay. Oh, okay. Now, with that, we'll take a quick break, and when we come back, we will continue with this conversation. Please stay with us. Welcome back, and thank you for staying with us on the conversation. If you're just joining us, we've been talking about HIV/AIDS and the goal that Nigeria has set come 2030 on how to eradicate AIDS in Nigeria. And the question we're asking, or we're talking about is if we will be able to meet this goal by 2030. And we'll be discussing with Dr. Nesochi Okeke-Igbokwe. We've been discussing with Dr. Iorhen Akase and also Dr. Olaoye Omolola. Now, let's come back to you, Dr. Omolola. There's been dwindling donor funding. I remember Dr. Okeke-Igbokwe mentioned this, earlier. There's been dwindling donor funding and also internal challenges. How realistic is this goal with these challenges?
Okay, thank you for the question. It's actually true that there has been issues, challenges about funding. Well, one of those things is that for proper distribution of resources, one of the targets of this HIV treatment is that even at primary health care level, that people should be able to access health care. You understand? But when there is issue with distribution of funding, these areas might be underfunded, and people accessing healthcare in this sector, in this lower level of healthcare, can be an issue. And all these grassroots are places at the rural areas where there are people who are actually living with HIV, and when they don't have access to those care, they might not be able to get the needed treatment, and with not being able to get the needed treatment, the progression of the disease occurs. And we used to say that when there is low level of viremia, there is undetectable is equals to untransmittable. But when this is not the case, when there is high level of viremia, people can easily pass it to another person via the sexual transmission routes. So in this kind of situation, we need the government to actually do better in terms of funding. One of the people that have helped so far is the partnership with USAID, which has helped to allocate resources to Nigeria for us to have access to healthcare for people who are living with HIV, to have free access to antiretroviral medications, which could be very expensive. For instance, the use of injectable is not yet present in Nigeria because it is very expensive. And this one would even ensure people to be able to commit to using their medications, because these injectables are used once in a month, some once in 6 months, you understand? So that's my own take on it.
All right, now Dr. Okeke-Igbokwe, now Dr. Omolola just mentioned how, what key measures are needed to sustain Nigeria's HIV response, in the long term. But then, coming to you now, how can partnerships with, United States government and also the Global Fund in supporting Nigeria's response, to HIV evolve to actually ensure, that Nigeria can sustain progress towards its 2030 target?
So those partnerships are critical and they are key. And we need to ensure that Nigeria continues to maintain and fortify those relationships to obtain that global funding. With that said, we cannot be completely dependent upon the donor funding. What will Nigeria do to ensure that they are allocating funds on a domestic level appropriately and accordingly? So this comes down to having the strong leaders, the appropriate leaders, those that have the best interest of the Nigerian people at heart, to ensure that they are actually allocating funds accordingly and appropriately. We also need to take a look at the data. What is the data showing us in regards to HIV and AIDS in Nigeria? Yes, prevalence continues to decrease over the course of time, which is great, but are we able to really pinpoint in a data-driven fashion what some of these barriers are and strategies that we can implement to improve outcomes for all Nigerians? So yes, continue to fortify and strengthen those relationships with the other powers that be abroad for donor funding. But I think we need to take a look within as well to determine what we can do to make things better for all Nigerians with the resources that we have at hand.
All right, now let's finally hear from Dr. Akase now. While you give your final thoughts, how do you think, or how is the National Agency for the Control of AIDS, that's NACA? Because earlier Dr. Okeke-Igbokwe talked about gender-based violence as well. How are they addressing gender-based violence and its link to HIV risks, particularly for women and girls?
Yeah, so I think this is an area that is very important, and I think NACA has done a lot of work, along this area. Most importantly, the screening and the initial care for women who have suffered violence, whether that is from rape or from domestic violence or from underage, exploitation. Most facilities there's been an algorithm that helps people receive care, when they come, to hospital. So, there's a lot of, they assess them for, risk for HIV, and they give them the initial care they need to receive. Of course, most of this care has been cascaded down to, smaller facilities as well. So they're able to, not just assess them, provide initial care, including post-exposure prophylaxis, which is what you give to people who have been, abused or suffered violence, and they are at risk of assessing. Once the risk of getting HIV is assessed and it's high, then they're able to receive post-exposure prophylaxis, which is drugs or treatments that are given to make sure that they do that. So my last thought, really, if I got you correctly, is one of the issues, one of the challenges we're going to have rather, with HIV care and integration is the issue of healthcare worker attrition. We know that resources, and it's not just finances, resources for providing care, whether it is for people who suffer violence or people who are coming HIV for the first time, a lot of people who have experience with these things are leaving the country. And we know now that even though we have numbers, the numbers are not there, and most experienced hands are leaving the country. And I think if we're going to, improve the quality and the reach and, the quantity of care we're going to provide people, not just those who suffer violence, but in a cascade of care for HIV generally, we need to look closely at how we can retain the experienced hands. Most of the people who have been HIV care over 10 years, we just up and leave. And all of that experience, all of that training, all of that, structure that the person carries just leaves with them.
Okay.
So the issue of healthcare workers, leaving the country, is a big problem, and it must be addressed if we are going to achieve this goals that we have.
All right.
Yeah.
Well, thank you so much, gentlemen and ladies, for your take on this very, very important conversation. It was quite an interesting one. I'd like to thank Dr. Iorhen Akase, Consultant-in-Chief of Infectious Diseases Unit, College of Medicine, University of Lagos, and LUTH. We'll also love to thank Dr. Nesochi Okeke-Igbokwe, CEO, Dr. Nesochi LLC, Internal Medicine Practice, New York City, and also Dr. Olaoye Omolola, Resident Doctor, Internal Medicine, Federal Teaching Hospital, Edo Ekiti. Thank you so much for your time.